Good morning, good evening, and good afternoon to people in Ghana and Ethiopia. I think I do know some of you. So hopefully I had actually spoken to a couple of people, and then uh, what we talked about was like, cardiac support devices in itself is probably not the best topic to have. I think a general overview of cardiogenic shock and then support devices is what we sort of came up with. Uh, can you guys see my screen?
Yes, we can see it. It's not in presenter mode though.
Because it's not telling me if it's showing the screen or not. That's why I was, yeah. Right. You guys can still see my screen, right? Okay.
Yes, and it's in full mode.
So we're going to talk a little bit about cardiogenic shock and a little bit about support devices and a very few selected studies. I have no conflicts. Want to give a shout out to Dr. Michael Flanagan. He's a colleague of mine. He's a cardiologist, is a transplant cardiologist who has helped a lot. And I've got some of his opinion on things, and he was helpful in letting me share some of his slides as well too. I'm actually trying to get him to give you guys a talk. He's actually a phenomenal teacher, so hopefully I'll get him to agree to that. So we're gonna talk a little bit about we're gonna define cardiogenic shock and classify it and look at some of the data about mortality and classification. Some use of inotropes, although we're not gonna go too far into that. I understand the types of circulatory support devices, the pros and cons of each of them too. So along that line, we're gonna talk some look at a little bit of the Swan Gans also, and just a very brief literature review. Okay, so let's start with the case. 57-year-old with non-ischemic cardiomyopathy presented to the ED with chest with fatigue and dyspnea. His last EF was about 25% in 2022. Denies changes and is compliant with his medication, fluid restriction salt. He takes Entresto, Toprol, spironolactone, empagliflozin, everything else. Of note, his cardiologist has slowly been coming off meds because his blood pressures are low. Um, on presentation, his heart rate 79, blood pressure is 86/57, respiratory rate 22, standing 93%. You see JVD on exam. You hear a 3 out of 6 systolic murmur, and you hear crackles on bilateral lung basis. He's lukewarm and he has pitting edema. Labs are mentioned, which is fairly unremarkable-ish, but the lactate is up to 2.8. Patient undergoes a SWAN. These are his SWAN numbers. RA is 14, RV is 24/12, PA is 24/10, wedge is 20, cardiac output and index of 3.7 and 1.6. What is the diagnosis? Um, I'm gonna save that part because it's like this is like a straightforward case, right? Like we're gonna and exam taking strategies. Since we are talking about cardiogenic shock, the diagnosis here is going to be cardiogenic shock. But keep that case in mind as we go through some of the other data. Okay, so how do you define cardiogenic shock? Cardiogenic shock is systolic blood pressure is less than 90, or supportive measures needed to keep systolic blood pressures greater than 90. By supportive measures, I mean you're either on pressors, inotropes, or have mechanical circulatory support devices already put in you. Uh, uh, with a cardiac index of less than 2.2 liters per minute per meter square. And I said index, not output there. Uh, with evidence of hypoperfusion, you have to have one of these. You can have more, but one of them is there to sort of classify as cardiogenic shock. And this is relevant later. We'll come back and talk about it in a second. But the things that are there for the hypoperfusion are elevated lactate, urine output, like decrease in urine output, AKI. Hepatic injury is a common one that you'll see. Altered status because you're not actually perfusing the brain as much, cool mortal extremities. Um, so understand I said cardiac index, not output, right? And I say with evidence of hypoperfusion is because you'll end up finding a group of patients, the patients who have chronic heart failure and who have actually they have adapted to living with cardiac indices of 1.8, 1.9, 1.6, in fact, even who walk into the hospital and are functional with that part unless they're classified as decompensated heart failure as opposed to cardiogenic shock unless they have evidence of endocrine dysfunction. And then this sort of definition is there to make that distinction a little bit between shock and what is not shock. Classically in med school, we used to get taught about like this 2 by 2 matrix, dry, wet, warm, and cold is how we used to get taught about. Can you guys see my cursor? Can you guys see the
Yeah,
cursor? Sorry.
yeah, yes, we can.
Okay, cool. So the very classic cardiogenic shock is the wet and cold, right? Like, so you have low cardiac index, so you're kind of cold, and you have a high SVR and an elevated wedge, which sort of makes you wet part about it. Okay. Vasodilatory shock, which is not cardiogenic shock, is warm and dry, which is typically your septic shock, is where it'll come up as you have your cardiac index is up, you have normal wedge, normal to low wedge, and you have low SVR, and so that heart's pumping away. And then there is like a combination of either of those to the mixed cardiogenic shock versus the euvolemic cardiogenic shock, where the patient is dry, but the indices are low. And this is sort of where the heart failure shock sort of comes into place. That this can happen in heart failure shock. Understand this part, like for shock in the very basic, simplest terms, it is like, the heart's not the functioning, right? Like the pump is failing. So pump can fail because, well, just the squeeze is not there, or the other reason is like, if there's not enough circulating volume, or there's too much resistance on the other side. So that's sort of how I would think about all of this, right? So if the pump completely fails and there's enough fluid to push, that's your dry, cold, euvolemic cardiogenic shock. Pump is failing, there's too much fluid. That's your classic cardiogenic shock. Pump is working great, but there's nothing in there. That's your warm, dry, vasodilatory shock, or less things are there. And then there's the last one. Uh, uh, Pump is failing, but there's enough, so that combination of it is there. So that's how you sort of think about, in the simplest terms, about how do you classify shock and what is it that where you should sort of look for problems. Um, so common etiologies of cryogenic shock, if you think about it, like, so the way we've described it is like it's the pump that's failing, right? So it's all mostly related to that part. So you have myocardial infarctions with mechanical complications like VSDs and things. You have decompensated heart failure. We talked about it. Myocarditis is one of them. The one that gets missed quite frequently, which is starting to get more recognized here, is Takotsubo's, right? You don't necessarily have to have an MI. You can have Takotsubo's cardiomyopathy from any sort of adrenergic surge, or the classic old broken heart syndrome is how you call it. Like, I mean, we see this now in septic shock. We've seen this now in like just respiratory failure as well too. There are any number of causes that can cause Takotsubo's cardiomyopathy, which can then sort of lead towards cardiogenic shock because the heart is stunned and dilated and it is not functioning effectively. It's an ineffective heart pumping, right? So that leads to cardiogenic shock. Peripartum cardiomyopathy is a common thing, valvular heart disease. And then you can see this with heart transplant rejections as well too. PE is a big cause of cardiogenic shock too. This is a more exhaustive list of it, where I put in, like, in this article they kind of mentioned all other reasons also, going back down to, like, post cardiotomy. There's global ischemia, tamponade, things like that. There's other causes as well too. This again, while this looks like a lot more, this is not entirely an exhaustive list. One of the things that was there is, like, excessive negative inotropes or vasodilator medications that can do that as well too. One of the common under-recognized causes for cardiogenic shock, which we were seeing, which we were not recognizing, is starting now we recognize this a lot more, is the use of diltiazem. Diltiazem is there in the algorithm for trying to treat atrial fibrillation with RVR, right? Like, so it's either diltiazem or beta blocker metoprolol using to sort of slow down the heart rate. Except diltiazem is a negative inotrope, and so if you give that in patients with EFs less than 40%, you can actually push them towards cardiogenic shock, and uh, 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 that is also something to keep in mind that we have started to recognize a lot more today. Uh, okay. So when we talk about cardiogenic shock, so when patients get into cryogenic shock, there's sort of like this notion of a downward spiral, right? So myocardial injury, your cardiac output goes down. If you think about it, hypotension, then systemic perfusion goes down, and then you start seeing the end organ damage. Remember when we were talking about like the AKIs, hepatic functions, and all of that? That all starts to occur, and that can lead to death, or like if it's not gotten that bad, those sort of sort of set off an inflammatory pathway which leads to more vasodilator release and then can cause like coronary perfusion can get hampered, and then you get now your cardiac function and itself is going down, and so this is like a vicious cycle that happens, and if you don't break it, eventually leads to death for patients. Same thing in a different way, sort of trying to think about it like what is it that is contributing towards the cardiac decrease in cardiac output? One is a pump function, the other one is volume overload, sort of putting too much stress on the heart to do that part. And so where are we trying to target things to sort of improve your cardiogenic shock? Okay. Now, in recent times, shock has now started to be classified by the SCI classification, which is Society for Cardiovascular Angiography and Interventions. This is the staging system for cardiogenic shock. So it goes from A through E. A is at risk, where they have factors for cardiogenic shock, but they're not showing symptoms of it right now. So think of it like your patients with EFs of like 20%, 10%, and all, but they're walking around fine. They have no end organ perfusion. Their blood pressures are fine. They're on meds. They're doing okay. B is the beginnings of cardiogenic shock, which is like, so you have relative hypotension or tachycardia, but you're not seeing the hypoperfusion yet. So this is where B and C is where you want to sort of try and do as much as you can for the patient because you're sort of like just starting the spiral, but you haven't gotten quite there. So the hypoperfusion has begun, but you're not seeing signs of it so far yet. So these are the ones who are hypotensive, and the maps have gone down below 65. The systolics are less than 90s or 80s sometimes. And they're starting to get more and more tachycardic. And this is early signs of that. Like a tachycardia in a patient with an EF of like 5-10% is sort of a little bit of a scary thing, right? Like, because you're understanding the part there is like they have patients who have like EF so lows of 5s and 10%, they have a very fixed cardiac output, or even when patients have certain types of valvular disease, they have a very fixed cardiac output that's going on. So what the heart's trying to do is normal compensatory mechanism of trying to ramp up the heart rate to ensure that there's a cardiac output. If you start seeing that, that should where the idea is not to slow down the heart rate. The idea is to find out what else is going on so that you can fix that before the complete decomposition begins. Uh, Sky C is hypoperfusion. Now you're using vasoactive or NMCS support. So they're hypotensive. You started them on either dobutamine or milrinone as an inotrope, or you started them on pressors like Levophed, dopamine, whatever your pressor of choice is, and then or they have like balloon pumps and impalas and tandem hearts and all. So that's your Sky C. D is they start deteriorating despite all of that, meaning you have all of this and there's a continuing progressive decline. Your organ perfusions are getting worse. You're providing more and more escalating amounts of support for that part. E is extremis, where there's either in CPR or we're going on ECMO, because that means all other supports has failed, and ultimately we are going down the pathway of putting patients on ECMO to go on complete bypass at that point. So that is your escalation slash classification for sky staging. So uh, as expected, as I was telling you about, so the overall mortality starts to climb, right? Look, so this is A, B, C, D, E. E is here. As you start seeing that the mortality start to climb up, um, the light bluish one is the ICU mortality. The hospital mortality is higher. As you can see, there's not much to be said for A and B. They're usually under 10%. And C is also somewhere there, 10 to 15. D and E start to see a dramatic rise in it. Now, this is where it gets interesting because, like, well, the if you look at the odds ratio for mortality, and if you're using your A as a reference part because they're sort of okay and out of the hospital, if you will, uh, it goes up to like eight, anywhere from 6 to 12 times the odds ratio for E. So this is a fairly lethal disease that is there. And one of the things that makes it lethal is the fact that it is fairly under-recognized. Because for the most part, people will think about shock, and then you see tachycardia, and the first response is always, let's give like a liter bolus, if you will. And when you start giving these patients a liter bolus, they don't improve. They actually tend to worsen, and now you're already behind the ball when it comes to in terms of trying to resuscitate patients. So that's usually the reason where it's sort of under-recognized early upfront. Now, there's lots of data to show that part. There have been multiple studies done which say that like it's an under-recognized disease, and so by the time you see patients, you're seeing a lot more in the Sky C part about it. Hopefully, before they get to the D. Looking at the same initial like this article, which was a review of all the data that was available. This was from 2019 in JACC. When you look at the shock in terms of mortality in terms of staging, it's an interesting thing, right? So when you look at when they come in with cardiac arrest, right? If there's a cardiac arrest in the diagnosis of it, obviously every stage the mortality is significantly higher than if they did not have a cardiac arrest. So, the gap starts to close somewhere in D and E because obviously uh, those patients are likely to die in any case unless you have advanced support available in your hospital. Uh, when you look at the mortality here, now when we're talking about early versus late deterioration, I mean, in this study, what they said about late deterioration was like 24 hours later that the patient deteriorated. So vasopressin. So it was vasopressin requirement after 24 hours of admission. So if you came in with A and went on vasopressors, then the mortality jumped up. Remember, when you come in with A and you go on vasopressors, you've jumped to category like Sky C, right? So what it's saying is like if you have progressed in any of these cases, if you have came in at a stage and you've progressed to the next stage or the stage higher than that, obviously you're not like things are going wrong here, and that's when your mortality is higher. If you came into the stage and we were able to keep you at that stage itself, your mortalities are, I don't want to say lower, but they are better compared to if you were continues to progress. And that sort of makes sense, right? Like the heart is failing. If you're able to stabilize it, the patient is likely to do better. If it continues to get worse, then you're not. And this is what this slide sort of suggests in that part. Oh, um, the one other thing that interesting part that came about was like, so there are a few flavors of cardiogenic shock. One is the ACS flavor, or the AMI shock is where you'll see it is where there's an normal person, there's an acute insult like an MI, and the heart doesn't work as well. And they're causing shock, and so you're having and so their mortalities is different from say the heart failure, which is chronically the other organs have sort of adjusted to the lower cardiac output and indices, and so the way their body has approached to is slightly different. Um, as is expected, if you come in with an AMI shock and you're in Sky Stage E, your mortality is upwards of 80% because essentially you're having a cardiac arrest as you're having your MI. If you're not going on support, you're likely not going to survive, right? So D and E are much higher mortality in the AMI shock as compared to heart failure shock. That is there. Okay, so far we've talked a little bit about cardiogenic shock. It carries a high mortality, right? We're talking like on an average, it's about 60% mortality for cardiogenic shock. Uh, it is under-recognized, and I recognize that like I did not give you enough data to make that point, but it is an under-recognized problem. And as this last slide will suggest, there's start to see two flavors of it, which is the acute MI cardiogenic shock or heart failure cardiogenic shock, and we'll sort of start making that distinction as we go along now. Questions so far? I'll keep going. Okay, I'll keep going. So let's talk a little bit about the Swan gas catheter. My understanding is in some of your hospitals you do it now, in some others you don't. But I think in any case, it's sort of good to understand a little bit about Swan. This is not an exhaustive talk. Any one of these topics can be a topic in itself, and so I'm going to keep it a little bit sort of just the basic spot for now. So Swan, or a PA catheter, as it's sometimes called, is a balloon-tipped catheter which is inserted. Like it's just like any other central line that you'd put in the IJ. It was actually designed for the subclavian, but we do it more commonly in the IJ now, in the right IJ. So what it does is it measures the right heart pressure. So you'll get measurements of your CVP, your right atrial pressure, your right ventricular pressure. Uh, then you'll get the PA pressures and the wedge pressure that is there. And then you can use either the Fick equation or the thermodilution technique to measure cardiac outputs. Now, depending on the thing, so there's a thermistor at the end of it, so you can actually measure the cardiac output from the just the saline flushes that you're getting, or the Fick is what more people will routinely use for it. You get the mixed oxygen saturation. Now, everything else is calculated. So to be honest, there's like the PA pressure, the wedge, the CVP after insertion is what these are the three things you get, and the mixed venous. Every other number is a calculated number. So you get your SVR, your pulmonary vascular resistance, or your cardiac output power. So those ones are all calculated numbers that you'll see. When a swan is placed, and this is the left one, this is your proper positioning. That is like the tip has gone through your RA, RV, this is your main PA, and then it's gone into one of the main branches of a PA. Now, it has just crossed the midline, it is right there, and that's probably the perfect positioning for it. This is a bad placement, right? And so it's gone all the way across. Hopefully, you guys can see my cursor, and this can you guys hear my voice? Sorry, I just saw the text come through.
Yeah, I can hear, so I'm just wondering if anyone else has an issue. So I
All
think
right.
that person should log out and log back, and sometimes network issues can do that.
Okay. All right. So going back to this one, like this one is really not in a good place and it actually should be pulled back right away because here you're not in your main PA, you're almost closer to the chest wall at that point. And so the problem is when you actually dilate the balloon to get a wedge pressure, you can cause a PA rupture. Uh, PA rupture carries a well, if you don't have IR or cardiac surgery available, no, I shouldn't say available, readily available, the mortality is 100%. If you have them available, readily available, meaning like you recognized it first, you recognize the problem, then you turned off, like if there's anticoagulation, you turned off, then you quickly recognize and call somebody, then the mortality drops to 80%. So this is a bad problem to be in. And so when you place it like this, the standard practice is to get a chest X-ray quickly to be able to understand where the tip is to be able to pull back. And this is one of those things that uh, we will also get like routine, like daily chest X-rays because swans can migrate. It's a catheter. It can obviously float forward with the flow if that is there. So this is an important part of PA catheters to understand that. Now, there are contraindications. Now, the contraindications are RVADs, patients who have severe PH who have Eisenmenger's reversal. And when I say RVADs, because remember, RVADs are right ventricular assist devices, so they're placed in the RV and they're just sort of like suctioning out blood. So when you're pushing the catheter in, this can actually get trapped in there and like just stop it. So that's not a good like so RVADs is an absolute contraindication. We will not place it. Uh, severe pH or when there's Eisenmangers, right? Like, so there's already reversal of flow, meaning there is a ASD or a VSD somewhere where you're bypassing your right-sided pressures are bypassing into the left. You potentially risk going in that way and the catheter getting stuck. And so that's a problem. So we won't do it. Left bundle branch is also a problem where we won't do it because um, if you have a left bundle branch block, uh, when you're inserting the catheter, like the tip, it's a flow directed catheter, right? So sometimes you can, when you're inserting it, you can cause a transient right bundle branch block. Now, if you already have a left bundle, and then the tip touches the RV free wall, and then like a right bundle occurs, the patient can go into complete heart block, right? So not a good thing to do. You're trying to do a procedure and the patient goes into complete heart block. Usually these patients are undergoing a swan because they're already in cardiogenic shock, and then they go into complete heart block is not a good thing to do. There are nowadays called pacing swans, meaning they have pacing wires attached to that part, so that when that happens, you can immediately take over and do it. Uh, I'll be honest, I haven't done much of that. I do know that there are like we will sometimes ask cardiology to place a pacing swan under fluoro for us, as opposed to us doing a swan at the bedside, just to be on the safe side about it. Uh, uh, Persistent left SVC. So this is a like a congenital abnormality, and I'm trying to remember. It's about like 5% of patients or 10% of patients do have that, and this one will go into a different direction, and so that's uh, uh, that's where we won't do it. If you have an RA or an RV mass, again, because like no idea if there's blood or something, you're risking it getting entangled there. Now, complications is a central line, so your standard complications apply, right? So there's bleeding, there's infections, there's pneumothorax while you're trying to place it. But the other ones we sort of talked about are right bundle branch block in about 5%. You can have sustained VT as well too, because like you've triggered it, you're like just like how you would do in a central line with a guide wire, you could hit something and cause a VT to happen. Uh, uh, so that's it. Now, these are flow directed, so when you're advancing forward, the balloon is up. Uh, 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 so when you're trying to get there, sometimes people have sort of withdrawn it with the balloon being up, and that can actually damage your uh, uh, the valves that are there, and also like sometimes can cause balloon rupture. So now you have a piece of plastic somewhere in the pulmonary circulation, which you cannot do anything about. So those are things to keep in mind. Catheters can get knotted. This is one we see in like when people have severe RV dilation. Like I remember I tried to put in a bedside swan on a patient with whose RV was 7.5 centimeters, so it's like severely dilated. Um, I realized that there was a problem, and thankfully I had an ultrasound, like I had my focus machine at the bedside to be able to sort of figure it out later. But it was starting to coil on itself, and so we had to quickly take it out before it caused a knot there. And the last one, the dreaded complication we've already talked about, is PA perforation, which carries such a significant mortality. Okay. So normal hemodynamics when it comes to swans. So RA is 0 to 7. I mean, you guys all know this part. Like RV is 15 to 23. PA is like 15 to 25 and 8 to 15. With the mean is less than 20. Actually, I should have changed that to say like less than 15 is considered normal, not less than 20. Wedge anywhere from 6 to 15 is considered normal. Indices, is 2.8 to 4.2. So when you insert it, the first waveforms that you start seeing are the lower ones where you have the RA pressure. Notice here it's under 10 typically. It can go higher. Then you start seeing when you enter the RV, because this is a flow directed, so how you're realizing which chamber you're in is purely based on the waveforms that you see. And you also have a rough sentence of how far it is. So at 20 centimeters from the IJ, you should probably be in the RA. At about like 25, like about 30-ish centimeters, 25 to 30 centimeters, you should be in the RV. And then you'll start seeing the systolic step up, like the systolic pressures start to rise because RV is the bigger contractility one, right? Like, so you start seeing pressures go up there. Then you quickly push through because it's flow guided with your balloon up and it enters your PA. If it hasn't coiled on itself, it'll get enter your PA. And I'll show you a better image of it. You'll start seeing like diastolic step up, your PA pressure start to show up. And then when you actually end up wedging it, then the pressures drop down a little bit, and you start seeing the what we end up calling the left atrial pressure, but essentially it's a wedge pressure, right? So this is probably a better representation for it. So when you're in your RA, you'll start seeing your dichrotic notches, your A waves, V waves. As soon as you enter the ventricle, you'll start seeing this massive swings there because the ventricular pressure is higher. But it comes down to the RA part, right? Because at diastole, when the valves are open, your RV diastolic is the same as your RA pressure. So that comes down there. When you enter the PA, notice the only difference is the systolic does not change, right? Because the RV is generating the forward flow of the pressure part about it. What changes is the diastolic. So this is called the diastolic step up. So your diastolic pressure has now gone from whatever 0, 5, something like that to like 10, 15 range. So for you to understand that the PA is there. When you see suddenly start dampening like that, because you're moving forward with the inflated balloon, you suddenly see a dampening part. That's when you have completely occluded the flow, or you have wedged essentially. You shouldn't be pushing forward anymore, and that is your wedge pressure. Now, obviously that's a range, and so you don't just take it at the range, like you can't just take that. So what you do is you take at end inspiration at end expiration, sorry, is when you will measure your wedge pressure. Like you can move the cursor down and just sort of like look back at the line and say like where it was. So common, some useful equations that sort of keep coming up is good to know is TPG is transpulmonary gradient, which is the mean PA pressure divided minus the wedge. When we calculate the PVR, or the pulmonary vascular resistance, it is like PA pressure minus wedge divided by your cardiac output. If you multiply that by 80, that comes up as 9. These are otherwise called Wood's units that is there. SVR is MAP minus RA pressure divided by cardiac output. Uh, PAPI is systolic PA pressure minus diastolic divided by the RA. PAPI is a relatively newish, well, probably in the last 5, 10 years, concept that has actually taken hold in Swan now. It's a hemodynamic parameter that talks about the contractility of the right ventricle. So the right ventricle is one of the ones which is not as well assessed. And now, finally there are echo guidelines for how to assess RV, and also how to assess severity of RV. But in the meantime, this was probably the first one which started talking about the RV. So if the PAPI is greater than 9, that means the RV is sort of contractilating decently. It has normal ventricular function, or decent ventricular function, I'd say. Zero point 0.9 or less, and now you start worrying about like RV failure. Is there's some sort of an RV impediment going on? The cardiac power output, as cardiogenic shock has evolved, this is also gained a lot more uh, 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 notoriety about it. This represents the ability of the heart to pump blood, and so it's the actual work that it's doing. It's measured in watts. Um, so it is MAP times your cardiac output divided by that. So if the output is low, I mean, then as you can imagine, that sort of means that your heart is failing, and so could be heart failure, could be other things as well. If your output is greater than 1.2, then the heart is working really hard at that point. So things to keep in mind about these common cardiogenic shock algorithms that we'll talk a little bit about, not as much, but we'll talk a little bit about like how we escalate when we are talking about support. Okay, so when you see a PA catheter, essentially what we're doing it for is the volume status function, LV volume status function, and pulmonary pressure, right? So the way we get our residents and fellows to talk about it, like when you see this one, it's not just about like saying this cardiac index is that. We'll ask them to say, hey, what's your RA pressure? What's your PAP? Like when we talk about RV function, what's your PAPI? What's your the RA by wedge? We'll look at the systolic pressures, and we'll look at ask them to talk about the wedge pressures. Uh, then we talk about the cardiac output and index, which has been measured to sort of say like, hey, this is your complete assessment of like volume status versus your whether you're in cardiogenic shock or not. Because all the cardiac output and index will tell you is that you're in shock. This sort of helps you decide like how are you going to approach shock. Are you going to diurese the patient more? Are you gonna give them more inotropic support? Are you gonna do a lot more afterload reduction by giving them vasodilators and drop down their maps further? Which of these three sort of parameters are you actually utilizing to make your cardiac index appear better? Okay. Uh, Okay. And then you finally come to the diagnosis. After you've said all of that, that's when you sort of think about what is it that you're doing, what is your diagnosis, and this is sort of like a systematic way of trying to approach the SWOT numbers. Now, just a little plug here. I think, you know, I'm talking a little bit about swans here. The general notion, this is true for most people in the United States, and I'm fairly confident it's true across the world, is like you say swan, like, hey, the guy needs a swan. The first and foremost always reaction is like, well, swans have been shown not to be useful. That's true, but understand the context of that statement. Context of the statement was like the study that was done in the 1996 or 98 by in Annals, which gets a lot of notoriety, is like, well, swans are not helpful in everything. Swans are helpful in a defined population of things. And swans are, that study also said, was clearly what it also showed was, if you go back and look at the study, is like, uh, if you don't know what numbers you're looking at and what that actually means, like you have no idea what you're doing. If you have no idea what you're doing, you're going to make, like, statistically itself, you're going to make bad decisions, right? Like if you have bad information, you will make bad decisions. If you understand what those numbers say, well, one, do you think the numbers are valid? Are you able to troubleshoot this one? If the numbers are if the numbers are valid, and you interpret them properly, now you get to make decisions. So all of those things have to happen before you do that. And so we do place swans. In fact, there's a study going on which says like how effective it is in cardiogenic shock. And the latest set of guidelines that came out actually have taken that into account, where uh, um for cardiogenic shock, it is a 2B recommendation or something like that to place a swan. There's one to actually upgrade it further. We're part of a randomized trial to say like in a very defined population, which is cardiogenic shock, swan actually patients on a swan will do better as compared to who do not have swan. So that study hopefully will have data for it soon, but that's where we see. Like so again, I'm going to point out it's a very defined population, like heart transplants, decompensated heart failure, or cardiogenic shock is where we are actually doing this, where it is beneficial. If you place it for randomly for ARDS, septic shock, or like somebody who's having a GI bleed, those are not helpful, right? And that's where the problem comes. Okay. Uh, in the context of cardiogenic shock, few hemodynamic profiles which are helpful to remember is like, is it a RV dominant shock? Is it a biventricular shock? Or is it an LV dominant shock? And so I found this nice little table which sort of breaks it down in a nice way. Like in LV dominant shock, your CVP can be low, but and your wedge can be high. Now in RV dominant shock, think about it. Like, see, the RV is failing, so the blood's not going forward as much. So you're not actually like the pressures in the PA are not high. So your wedge pressure is also obviously not going to be high. So everything behind that is what's going to be the problem, right? So that's when you'll see your CVP wedge ratio is pretty high, your PAPI is pretty low. Those are the numbers you start seeing when we talk about RV dominant shock. In LV dominant shock is like the LV is not functioning well, so the fluid is backing up in the system, right? So your wedge pressure is going to be high, your CVP wedge ratio is low because your RV is still sort of working as well, and so your PAPI and all will be okay. In biventricular shock, where the LV is not working, RV is not working, it's I most of those numbers you can sort of figure out what it's actually doing. The wedge is the one which is variable because in part a wedge pressure is like, remember, a wedge pressure cannot be higher than your PA pressure, and your PA pressure is dependent on your RV. So if your RV cannot push out blood, your PA pressures are low, and so your wedge pressure is going to be like low-ish, right? Like you're not going to know that number as much. So that's why it's written as variable. So this is a sort of a simplistic way of sort of thinking about RV versus LV versus biventricular shock. Okay, so the original topic we've come to like 30 minutes later is about cardiac support devices. So This is a brief overview. This is not meant to be anything exhaustive, right? So use of mechanical support has as a rescue strategy. So it has evolved from being a purely rescue strategy to being now starting to become a major part of cardiogenic shock care. So what do we talk about when we say devices? At least as I understand, it's like it's the classic is intra-aortic balloon pumps. There's percutaneous left ventricular devices. These are your Impellas, tandem hearts, and there's a few other machines that are out there now. One of them is extremely promising. So hopefully that'll change the game a lot more. Then there's percutaneous right ventricular devices. These are different from surgical devices such as LVADs and RVADs, which are like you implant them. There's nothing percutaneous about them. And then there's obviously the end all be all is VA ECMO. These are typically your mechanical circulatory support devices. Now, indications can be many. So the common ones are cardiogenic shock. If you're doing high risk PCI, because when you say high risk, like they're likely to have cardiac arrest. If you have an osteal LAD lesion and they put a wire in, if it's like 99% occluded or 90% occluded, and you put a wire, you've effectively blocked off the coronary supply, right? And even for that brief a minute that it takes to get the wire across and dilate something, people can have cardiac arrest. So those are like thing in those situations, interventionalists will probably put in like an impella or a balloon pump to support the heart while they're doing it quickly to be able to do that part. So those are high risk PCIs. Cardiac surgery, obviously, post cardiac surgery and all. We talk about like ECMOs and balloon, like RVADs and LVADs and other mechanical circulatory support to help the patient go through surgery. Advanced heart failure is like pre-optimization prior to transplant versus like as a bridge to recovery as you're trying to get them on the right guideline-directed medical therapy, and also we can use that. And also sometimes in EP labs when they're doing their ablations if they think it's high risk. So, as you can think about it, there's two ways to think about it. Well, one is what are we doing to provide LV support versus RV support. So hopefully you guys can see the screen, this picture nicely. There's pulsatile flow, which is the intra-aortic balloon pump. It's a catheter with a balloon, which is placed in the descending aorta or into the near the aortic arch. So it's counter pulsation, meaning it like inflates during diastole and then sort of deflates during systole. The idea is like it inflates, it improves coronary perfusion, and also sort of decreases your afterload. So it does that to help support the heart is how it does. Now, when it comes to continuous flow devices, there are two types. There is the microaxial flow and the centrifugal flow. The microaxial ones are the ones which are percutaneous right now. So those are, well, actually, that's not true. There is a percutaneous centrifugal one as well too. So microaxial one, and I'll talk about it in a second. They place it in the through the aorta into the left ventricle and sort of like think about it like it sucks out blood and it sort of pushes the blood forward in from the left ventricle into the aorta. The percutaneous one that is there is called a tandem heart. So you do a transseptal puncture near the near your pin, like your foramen valve and that area, and ASD, like that area. You'll make a hole and you'll pass a catheter through it, where you're like constantly um, draining the heart out and then sort of putting that into the femoral vein. Now, the advantage of this is like while this is just pure cardiac support devices do not offer oxygenation, but you could attach an oxygenator onto this and help with that as well too, which is essentially what VA ECMO is. But instead of doing transeptal puncture, you're doing like a femoral artery and a femoral vein cannulation to be able to draw blood from there. Surgically placed ones are the LVADs right at the bottom. They'll make a hole at the or the center mags also, but like they'll make a hole at the left ventricle, sort of core it out and place a device which essentially sucks, takes the blood back and like you'll pump it back into the aorta directly. So microaxial flow, this is your impella essentially. Like this is the Archimedes screw principle, right? Like so, it's just sort of like it's a fast rotor of just spinning, which is so it's creating that suction to sort of pull the blood out, if you will, like the old way of doing it. It unloads the ventricle quite nicely, and because it's unloading the ventricle, it reduces the oxygen demand. So these are the classic ones currently, which has sort of cornered the market, if you will, is like the Impala CP, which is the original one. So there's the Impala 5.5. So the difference is, so when it says 5.5, this can provide a cardiac output. The device itself can provide a cardiac output of 5 liters, 5.5 liters. Remember, normal cardiac output is 4 to 6 liters. So this can actually literally take over your entire LV function. The CP was the latest versions went up to 3.8 liters almost for-ish. And so it had a little bit of angulation here, which both of them do. The blood comes in through here and like it is pumped out here. So it'll sit across the valve like that, so that you're taking it from the LV and dumping it into the aorta. Uh, So positioning is a problem when it comes to, well, it's not a problem. It's optimal positioning is obviously needed. So it goes from the aorta, so it has to go traverse the aortic valve, and then has to be like it should not be too close to the mitral valve. So it has to be from away from the mitral leaflet so that it doesn't get caught up in it. And tip of the catheter should be pointed towards the apex, which is becomes a problem. And it has to be at the optimal distance when it comes to there. So this is an MRI version, like how it sits across the aortic valve. It's almost, it should be closer, not touching it. So the positioning is a challenge, and so we do daily echoes on them or daily focuses to be able to calculate the distance to make sure it's an optimal positioning. Few things about the support devices. So they offer varying levels of support. Here's the first part, like balloon pumps will offer anywhere from half a liter to a liter cardiac output support. Impalas, like we talked about, is depending on 2.5 CP or 5, it's like 2.5 liters to 5 liters of support. It will do that. Tandem heart does 4 to 5 liters, and ECMO can do a lot more than that. The challenges comes is like what happens with all of it. So LV unloading is done by all of them except ECMO. So ECMO, depending on that, like we may have to place one of these other devices also along with ECMO to sort of help unload the LV as well. Otherwise, the pressure comes and then they start getting hypoxic as well too. Um, Cannula sizes obviously vary. Like balloon pump is 7 to 9 French. Like there was a time we would place this bedside. Now we don't do that anymore. To Impalas are 13 to 22, and ECMOs are like 15, like 18 to 22, like sort of in that range that they'll do it. Uh, so balloon pumps, there's no anticoagulation. Uh, Depending if you're 1 to 1, but other than that, every one of them has anticoagulations for it. Now, when not to use it? If somebody has a VSD, you can't do tandem heart, right? Because you're making an atrial puncture. Now you already have a VSD, and now you've sort of created a huge problem there. Uh, if you have peripheral arterial disease, one all of these can become a problem because these are all groin insertions, and the risk for complications is pretty high. If there's aortic dissection, you should not be doing them also because again, you don't know if you're going to the dissection flap or in the actual aorta for it. This is, in the interest of time, I'm sort of going to gloss over the slide a little bit because I realize that we're getting close to the time and there's a lot more to cover. But these are some good like ways to think about like when to not do it versus when to do it. And I'll probably be sharing these slides with you guys for you to take a look at it. RV support is the same concept, but it's on the other side of it. I'll tell you, RV support is not as much popular because supporting the RVs is actually more complicated than these devices are, and there's not much good data or good devices out there. There's a couple of good ones coming out now, which promise in trials. But for the most part, ECMO is the preferred approach when you're talking about it. Now, there's an RV Pella, Impella RVs now it's called, I guess, which can do the same thing, which sort of like instead of sucking back the flow, the blood, it sort of pushes it forward. Obviously, there's the RVADs, which are there, which will do the same concept as well. So putting all of these in one slide where we're talking about hemodynamic support versus complications and all of that. As you see, as we talked about, hemodynamic support from balloon pumps are low. 2.5, 5, and all of these start getting higher and higher support as we provide them, right? The limb ischemia also starts to change as the higher catheters that you're starting to put in. The anticoagulation risk that is there starts to go up. Hemolysis starts to change. The hemolysis part, like here it says low, by the way, but this is actually the Impala 2.5 and CP is where the real problem is, and we'll talk about that in a second. And how you manage the complexity of management. Balloon pump is fine. Impalas, we'll talk a little bit about the complications that you watch out for. ECMO and all requires high level of team management, and also that's where the support and what you can provide starts to change. Typically, let's say you have a cardiogenic shock and you went on one of these devices. Well, the way you actually go down further is, remember, if all of these, like, you can put any of the other devices, if it's inadequate support, you'll end up on ECMO. And that's sort of what this is trying to say, is like, at the end of it, the biggest support that we can provide to a patient is going on VA ECMO. Everything else is in an effort to try and not let that happen. And that's why ECMO or CPR is the Sky Class E support that we'd say. Complications of MCS, there's mechanical complications where if the device migrates, can damage the valve, vascular injury in placement, as we talked about it, limb ischemia, as we talked about it, that can do it. Infections are a big one because it's like another device, another line for source for line infection, right? Hemolysis is a big one when it comes to impellant. Again, we're going to be talking about that shortly. And sometimes they can do microemboli and cause like small strokes for patients as well too. Um, so the hemolysis occurs because of in microaxial flows occurs because the tip can sometimes because this causes turbulent flow around that area, and that can do it. Um, it's sort of like sucking out the blood really fast, right? Like, so if it's sucking out and your volume status is not the best, it can cause damage. And so a lot more hemolysis can occur as well too. Because a little bit occurs, the platelet activation and aggregation can occur. And so you can sort of have thrombus formation as well too. Then what ends up happening with hemolysis is like pigment nephropathy, and you have AKI, and you have a lot bigger problems start to happen. So typically, when you're trying to troubleshoot hemolysis in these patients, it's like, well, is the catheter in the right position, right? Because that's where the issue is. Is it a problem with the RV function? So not enough blood is going into the left ventricle, and so you're draining a dry left ventricle, if you will. So again, like a sort of a preload complication. Is it pump related? Is something going on with the motor, or there are a few other causes to think about too? Uh, and so this is sort of the whole algorithm we sort of talk about a little bit. And again, I'm showing you this because this is relevant when we talk about the danger trial. So when it comes to the last part about devices, it's about how do you approach it. So it's about two things. It's AMI, cardiogenic shock, is like typically the algorithm. This I picked up from European Cardiology Society guidelines. There, is it comatose, not comatose? If they're not comatose, then you look at the signs of cardiogenic shock, and then if RV failure is there, then you go to VA ECMO. If it's not there, then you use support devices. If they're comatose, then you go down this pathway. If the cardiac output is low, then you can consider it depending on how you assess the neurological function recovery. If not, you do regular standard management for post-cardiac arrest. Heart failure shock is different. When we talk about, like, first you have to be candidates for something. Are you a candidate for bridge to recovery devices, like say like an LVAD, or are you a candidate for transplants? If you are a candidate, then you start going down this pathway about whether you consider temporary support versus ECMO. And if you're not a candidate, then this mostly like we will not offer these devices to patients at that point. Um, Right. So I think there's a talk in the chat. There's a question in the chat. At one of those, at least I'm going to answer in the studies that is there. So typically, when you're thinking about it, when you talk about like common questions we get asked is like, hey, which is better, Milrinone? Are there differences? Because I showed you two algorithm. Is one versus the better? Is there data for AMI shock? So these are the few things I'll tell you. This is not an exhaustive talk. And if there are questions, I'll try and answer at the end of it. So the common ones, I think this addresses one of the questions in the chat. So this was a New England Journal study in 21, which says milrinone compared to dobutamine for it. It was a single center double randomized trial. So you're looking at a composite in a hospital mortality and other things. So you about 192 patients, and they were in various sky stages that were there. No swan, but you were adjusted and you could adjust it. Starting dose was one thing, but you could adjust the patient accordingly. Patient characteristics were same, but if you look at it, there was no real difference in the outcomes versus the mortality for it, like for the in terms of melanoma versus that. If you look at secondary outcomes of urine output, creatinine, lactate, no difference between any of them at all when it comes to milrinone or dobutamine. So no significant difference between them, primary or composite or secondary endpoints. But you sort of have to remember the pharmacokinetics of it, right? Like, so all of them act slightly differently. Dobutamine is quick on, quick off, meaning like, it can be turned off. And if I turn it off, the effect should be out of the system in the next 2 to 3 minutes. Milrinone is much longer here, if you see. Milrinone, the other part is it's renally cleared and also a little bit hepatically metabolized too. So in shock, remember we talked about as one of the markers is like AKI and LFTs, and this is where it starts becoming relevant, is like if they have AKIs and their renal function is going down, you have to be sort of careful with the milrinone aspect of it. Usually we don't have much of an issue with that as long as they're making urine. You just have to understand that you titration, once you turn it off, will still take a longer time to be in the system. Dialysis patients and all, we typically, it's a center-driven approach. We will typically not go down that pathway for dialysis patients because the clearance is variable. That's why we use dobutamine. Um, there was a question asked earlier about dopamine as a cause for it. Now, dopamine is, while it is used, there were studies in the 90s, early 2000s, we sort of, sorry, in the early 2000s, where we sort of moved away from dopamine as a inotropic agent because it had a lot more propensity to cause arrhythmias. Um, Vasopressors in the same New England Journal study to complete the answer for the question that is there in the chart. Vasopressors, there was a New England Journal study in 2008, and I don't have that here on these slides, which looked at shock all comers and it was a head-to-head comparison between dopamine and norepinephrine, and norepinephrine was better, especially like even in cardiogenic shock because it had a lot less arrhythmias, a lot less. It was like about 25%, a lot less. Uh, uh, I don't say like major arrhythmias. So we're talking about BTVFs, and that sort of thing was a lot less. So dopamine fell out of favor in terms of treatment for cardiogenic shock. So typically, if a patient is in shock, we'll still go on norepinephrine. First up, we are providing inotropic support. Then milrinone or dobutamine will come on board depending on the patient characteristics that we're talking about. That is our go-to for inotropic support and vasopressors in cardiogenic shock. Hopefully that answers that question. Now, we're talking a little bit about like heart failure shock versus AMI shock. So there was a single center retrospective review about it, which looked at 1 year mortality. So heart failure shock had less cardiac arrest, less need for vasopressors, and also the 1 year mortality was better. 30-day readmission was not. So when you look at the outcomes, you can see there's a clear difference as the p-value is also there. It changes between AMI shock and the AMI shock is higher as compared to heart failure. All cause survival to discharge, that was not significant. It does look like that, but there's a lot of overlap and there was not a significant difference between the two of them. Um, this was an older article about balloon pump in cardiogenic shock, and again, who are either so the difference here was it was early revascularization, assigned to receive balloon pump or not receive balloon pump, and so in this there was no real difference. Um, you have to take this with a grain of salt here a little bit, mostly because uh, the planned thing for an MI is early revascularization. So that's what this was about. Like, so adding a balloon pump at that point didn't necessarily matter. And so there was no real difference between the two of them there. Now, the most talked about trial in the last sort of a year is the danger shock trial. And, it's a fun name to talk about it when you say danger shock because it was done in Denmark and Germany, hence Dane and Ger. But it came out like danger shock, right? Like, oh, we were talking something crazy for cardiogenic shock. Um, it was international multi-center randomized trial for STEMI and cardiogenic shock. So they did like a microaxial pump, which is essentially an impella, plus standard of care versus standard of care alone. And anyone over 18 STEMI cardiogenic shock, they were randomized either in the lab while going to the lab or post PCI within 12 hours of it. And they had to run the device for at least 48 hours. So 355 patients were randomized to it. It was interesting. The mortality actually primary endpoint was significantly different, and we came up with a number needed to treat of 8. But the safety part was also significantly different, and we'll talk about that in a second. Was the number needed to treat harm was pretty high. So if you look at it, clearly the mortality there's a huge difference between the two of them that comes apart. But I want to sort of highlight this part too, right? So we're talking about moderate to severe bleeding. The odds ratio is 2 point, and it's clinically significant here. Limb ischemia, the odds ratio is 5. That's pretty significant. Renal replacement therapy, odds ratio is 2, which is pretty significant. So when we're talking about renal, so about 45% of their patients had severe morbidity associated with it. But at the end of the day, you can come back and say, like, well, that's true, but they're surviving. That's true. What so Danger Shock has spawned a whole lot of conversations because this is the first study which actually shows like a device might be helpful in the right setting for patients. Now, that's helpful, but the conversation that sort of needs to be tempered with is like you have to have the ability to take care of those patients too, like to minimize these complications. So I'll tell you, we did a lot of Impala CPs and 2.5 early in our shock program. And now we have switched to exclusively doing Impala 5.5 because the renal replacement therapy complication and the catheter moving and all of those things are a lot less. This was done with a CP. The study was done with a CP. I wonder what it would say with a 5.5, but 5.5 are surgically placed, and so that's why access to it is kind of limited. They're working on a percutaneous placement for it. If that happens, I think this will be a game changer. But till that time, the complications are actually very real, right? Like, and so it's not about placing the impella in the cath lab and improving their mortality. It's about can you actually take care of it after that? Can you do daily things to make sure that the catheter is in position? Do you have CRT and dialysis? Uh, 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 to be able to do it too. The last one we'll talk about is the ECMO or ECLS in cardiogenic shock after an MI. Uh, in the interest of time, we'll talk about that. Well, they're actually doing an early revascularization. Also, primary endpoint was mortality, and didn't see a difference in mortality for it, but the complication rates for an ECMO were higher. Um, so the risk of uh, so you're taking on the risk of complications doesn't necessarily show that early ECMO is helpful in these cases. In the case of an MI, right? So this is sort of a brief summary of the three major trials. I mean, I talked a little bit about two of them, the ECLS shock and the danger shock. The balloon pump shock 2 trial, I did not talk as much, but it sort of follows along the same things. Um, I just realized that this is my first version of the talk. The other one had more take-home points, but essentially, the one thing that I wanted to come off of this is like it's under-recognized, right? Think about like my understanding, and I've seen some of your in action is like you guys are very facile with focus. This is one of those things like when you're trying to think about shock, like have that in the back of your mind that this could potentially be cardiogenic shock because again, it's under-recognized. A quick focus will give you a good idea about it. If you guys are placing swans that understand the hemodynamics of it, like what actually does where, to be able to get a better assessment and to utilize the swan better about it. The use of MCS is rising. Um, know the complications, know where it cannot be used or where it can be used. Like I mean, like if you have bad peripheral arterial disease or you have like a aortic dissection Most of the support devices are off the question. If you already have a VSD, you can't do a tandem heart or that. Um, if you already have like renal failure, hemolysis, like renal failure, dialysis happening, Impala may not be the best choice. Balloon pump may be the best choice. If you're needing a lot more than half a liter support, balloon pump's not the best choice. Impala may be a better choice. So I think some of those things, it's important to understand that part. I didn't put this, so you can at the end of the talk, well, one of the when I you can ask the question is like, well, how is this then? How is any of these support devices helpful? The way it says like there's some recent data to show, and I was talking to Dr. Esther about it earlier before the talk started. The answer that is coming is not like one device is actually helpful. It is the shock team approach where there's a cardiologist, an intensivist, and a transplant attending who are or an interventionalist attending on this, talking through the process and early recognition of it, and then understanding if you can actually break the cycle in the sky B C like C stage of it before it gets to the D and E, where unless you have a transplant bailout or a LVAD bailout, the patient is going to die, right? Uh, uh, so the idea is to have a team approach to quickly intervene in the C stage of it, or even if the B part about it, to be able to do it. And the team approach actually versus the non-team approach is where you're starting to see some benefits. And uh, uh, our institution, my colleagues, Casey and a few others, had actually published that data about 4 years ago to say that the team approach is what is actually beneficial in these settings. And I did not show that data for now. Um, to end it, because we're pretty much over time. This is our sort of our algorithm for cardiogenic shock, where we talk about like how we go about like, is it LV dominant, RV dominant? What are we doing with that? What devices are we likely to offer patients, and how do we think about it so that we have a little better sort of a protocolized approach of how we are going about when we see a cardiogenic shock. Um, that's all I have. Questions? I know this was a lot, and I sort of ran through the last part when I realized the time.